Mood disorders are also called affective disorders. They are pervasive alterations in emotions that are manifested by depression, mania, or both. They interfere with a person's life and can cause long-term sadness, agitation, or elation. People have had mood disorders throughout history. Some examples include Abraham Lincoln, Queen Victoria, Jerry Garcia, and Mike Wallace from 60 Minutes. There was no treatment for mood disorders until the 1950s, but treatment today can be very effective, although there is no cure. Mood disorders are the most common psychiatric diagnoses associated with suicide. In fact, depression is one of the most important risk factors for suicide. The primary mood disorders are depression and bipolar. With major depressive disorder, the person has a depressed mood or a loss of pleasure in nearly all activities for at least 2 weeks. Symptoms of major depression include changes in sleep and appetite and weight, can be either more or less than the person's normal. They may also experience impaired concentration, decision-making, or problem-solving, and struggle with feelings of worthlessness, hopelessness, guilt, or despair. They may have fatigue or ruminate. About 20% of those with major depression will have delusions and hallucinations, which is referred to as psychotic depression. Bipolar disorder has two types, bipolar 1 and bipolar 2, and it's diagnosed when a person's mood fluctuates to extremes of mania and depression. Bipolar 1 has more mania episodes with some depression, while bipolar 2 has more depression with episodes of hypomania. Mania is a distinct period during which mood is abnormally and persistently elevated, expansive, or irritable, and it typically lasts about a week unless the person is hospitalized and gets treatment sooner. Symptoms of mania include grandiosity, decreased sleep, pressured speech, flight of ideas, distractibility, psychomotor agitation, and engaging in pleasure-seeking or risk-taking activities. Hypomania is a period of abnormally and persistently elevated, expansive, or irritable mood, and some of the other milder symptoms of mania. Hypomania does not impair the person's ability to function. They may be really productive. Related disorders include dysthymic disorder, cyclothymic disorder, substance-induced depression, seasonal affective disorder or SAD, postpartum blues, depression or psychosis, premenstrual dysphonic disorder, and non-suicidal self-injury. There are several theories on the etiology of mood disorders. In the biologic theories, the genetic theories state that there is a genetic component to disease transmission. Those with a first-degree relative who has depression are twice as likely as the general population to also be diagnosed with depression. For those with a first-degree relative with bipolar disorder, their risk is 7 times that of the general population. Neurochemical theories focus on serotonin and norepinephrine as the two major biogenic amines implicated in mood disorders. Serotonin has many roles in behavior and affects mood, activity, aggressiveness, irritability, pain, cognition, biorhythms, and neuroendocrine processes. Norepinephrine levels may be low in depression and high in mania. Norepinephrine energizes the body to mobilize during stress and inhibits the kindling process. Acetylcholine and dopamine are also being studied in relation to mood disorders. Neuroendocrine influences are also being studied as hormone fluctuations may affect depression. Some people with endocrine disorders may have also been shown to have mood disorders, such as the thyroid, adrenal, parathyroid, and pituitary glands. Psychodynamic theories look at the person and family. These include self-deprecation, ideal ego, mania as a defense against depression, depression as a reaction to life experiences, rejecting or unloving parents, and cognitive distortions. Some behaviors that are age-appropriate can mask depression, which can make it difficult to diagnose. For example, a child with depression may seem cranky or develop a phobia to school, hyperactivity, learning disorders, etc. Adolescents with depression may abuse substances, join a gang, engage in risky behavior, and so forth. Adults with depression may also abuse substances, develop an eating disorder, become a workaholic, or engage in other compulsive behaviors. Those with depression may also have somatic complaints, although this varies from culture to culture. Major depressive disorder typically requires 2 weeks or more of a sad mood or a lack of interest in life's activities, with at least 4 other symptoms of depression, such as anhedonia, changes in weight, sleep, or energy, and changes in concentration, decision-making, self-esteem, and goals. Major depression is twice as common in women as it is in men, and has a 1.5 to 3 times greater incidence in a first-degree relative. As people age, the incidence of depression decreases for women, but increases for men. Those who are single or divorced have the highest incidence of depression. Untreated depression can last from a few weeks to months or even years, although most will clear in about 6 months. Some people will have a single episode of depression, but 50 to 60% will have a recurrence of depression. About 20% will develop chronic depression. Symptoms can range from mild to severe. Some with severe depression will have psychotic features, about 20%. We talked about symptoms on the previous slide, but here they are again. Be sure to review the DSM criteria posted for you in the module or in your book. We use antidepressants to treat depression. If you remember from Chapter 2, we have 4 classes of antidepressants: MAOIs, cyclics, SSRIs, and the atypicals. Selective serotonin reuptake inhibitors, or SSRIs, are the most commonly prescribed antidepressants and are effective for most people. They typically have few side effects and are safe for most people, so patients are more likely to be compliant with their medications. SSRIs to know: fluoxetine or Prozac, sertraline or Zoloft, paroxetine or Paxil, citalopram or Celexa, and escitalopram or Lexapro. Tricyclics are the oldest antidepressants. They take 6 weeks to get the full effect, cannot be taken with MAOIs, and have anticholinergic side effects. Medications to know: amitriptyline or Elavil, and doxepin or Sinequane. Atypical antidepressants are used when SSRIs are not effective. Medications to know: venlafaxine or Effexor, duloxetine or Cymbalta, bupropion or Wellbutrin, and mirtazapine or Remeron. MAOIs are used infrequently due to the side effects and interactions, like hypertensive crisis if they ingest foods with tyramine, or other medications. They take 2 to 4 weeks before the therapeutic level is reached. Only one medication to know for this, and it's phenelzine or Nardil. Electroconvulsive therapy, or ECT, is used to treat depression when medications don't work or the side effects are too severe to tolerate. ECT is also safe during pregnancy, a time when medications may not be. ECT is not like it's portrayed in the movies. It's actually pretty anticlimactic. When a patient is going for ECT, they will be NPO after midnight. ECT is usually scheduled first thing in the morning, so you may have to get them up and get them ready early. When they arrive, they'll be put in a bed and an IV will be started. There's a psychiatrist and an anesthesiologist there. ECT can either be unilateral or bilateral, one side of the brain or both. Electrodes will be placed on one side of the head or on both, depending on what the psychiatrist feels would be best for the patient. They'll be given medications to sedate them and help them not remember what happened, along with a muscle relaxant. Patients are not usually intubated for ECT. They're more likely to be hyperventilated before the procedure or an ambibag used. When everything's ready, the psychiatrist will deliver the shock, which induces a seizure. The person does not flail around. Usually all you see is a little twitching, if anything at all. The seizure is short, and the patient is waking up within minutes. They'll be monitored for a while to be sure their gag reflex is returned and their vital signs are stable. Then they're returned to you. On the unit, you must continue to monitor vital signs every 15 minutes for an hour. The patient will probably be tired from the medication and may need to sleep for a while. If they mix breakfast, you'll need to be sure to save them a tray and offer them food. They may have some short-term memory loss or confusion and may complain of some muscle aches. People usually have 12 to 15 treatments of ECT 3 times a week. Some will continue to need ECT as maintenance therapy, and some will be fine and not needed again. There's no limit on how many times a person can have ECT. Places in our area that do ECT are Methodist and St. Vincent. Therapy is also used to treat depression. Most effective treatment is considered to be medication along with therapy. Patients may have interpersonal therapy, behavior therapy, or cognitive therapy. New therapies being looked at include transcranial magnetic stimulation, magnetic seizure therapy, deep brain stimulation, and vagal nerve stimulation. When assessing a patient with depression, you need to get a history from the patient. Keep in mind that depression can be exhausting and the patient may have trouble focusing on what you're saying and formulating a response. Be patient and don't try to rush them. Ask about previous episodes of depression and what treatment they have had. Ask about any family history of mental illness, including suicide attempts or completions. How does the patient appear? Those with depression will frequently look sad and slouch, not making any eye contact with you. Movements and thoughts may be slow. The patient may appear unkempt and unable to perform their ADLs. Mood may be described as hopeless, helpless, anxious, etc. They may feel like they're a burden to their family or that their family may be better off without them. Affect may be sad, depressed, blunted, or flat. They may be easily overwhelmed with noise and activity on a unit and may withdraw from all the stimulation. Thought process may also be slowed and they may ruminate or go over and over the same thoughts. Content tends to be negative and pessimistic, feeling as though things will never get better or that they can't improve. They may have thoughts of dying or of committing suicide, so doing a suicide assessment is really important. And it's important to ask about it directly, actually asking them if they're thinking about suicide or killing themselves. Some people with depression may have trouble with orientation, particularly if they're experiencing psychotic features. Memory may be impaired with depression, and they may not have a good sense of time. They may have trouble paying attention and concentrating. If they do have psychotic features, they may be hearing voices that can be very negative or experiencing command hallucinations that tell them to hurt themselves or others. Judgment may be impaired if they're having trouble making decisions. They may also be apathetic and think it doesn't matter what they do. If they've been depressed previously, they may have good insight into their illness. Otherwise, insight may be impaired. Self-concept is greatly reduced with depression. The person feels as though others would be better off without them, that they are good for nothing. There is frequently a sense of guilt for not functioning well or taking responsibility for things they have no control over. Roles and relationships become difficult. They have trouble going to work or school and have trouble carrying out their responsibilities. This carries over to home as well, and they can struggle to care for children, cook, and meet other household responsibilities. Depression can put a real strain on relationships, as the person with depression may avoid interacting with family and friends. Those with depression frequently struggle with appetite and sleep. They may lose weight because they aren't eating well or they're not interested in food. They may gain weight if they overeat. They may not do personal hygiene, and they may have sleep difficulties. We do have depression scales that can be used as part of an assessment of the patient. In your book is the Hamilton Rating Scale for Depression. This is used by a mental health professional to rate things like the depressed mood, guilt, suicidal ideation, insomnia, and more. Once the assessment is complete, you'll need to analyze the data collected. From this data, you'll come up with a nursing diagnosis. These might include risk for suicide, ineffective coping, hopelessness, or self-care deficit. Identifying outcomes for the patient will depend on the symptoms the person has, but might include the patient will be free from self-injury, independently carry out activities of daily living, have a balance of rest, sleep, and activity, evaluate self-attributes realistically, socialize with others, return to work or school activities, and be compliant with medications. Interventions to consider for patients with depression. Maintain safety. This may mean suicide precautions if the patient has suicidal ideations. Suicide precautions entail removing anything the patient may use to harm themselves, including their clothing if needed. Most hospitals have paper scrubs or something appropriate so the patient can remain covered but safe. The patient may need to be one-to-one with staff to ensure safety or have a suicide sitter. Promote a therapeutic relationship. Promote ADLs and physical care. The patient may require prompting or assistance to complete these. Use therapeutic communication. Manage medications. And provide education to both the patient and their family. Remember that suicidal ideation may increase when a patient is starting an antidepressant or a dose increased, so both the patient and the family need education on this. Bipolar disorder involves extreme mood swings from episodes of mania to episodes of depression. It's second only to depression as a cause of disability. The lifetime risk of bipolar is at least 1.2%, with a risk of completed suicide at 15%. It occurs about equally between men and women, and it's more common in highly educated people. The first manic episode occurred somewhere between the teenage years and their 30s. A diagnosis of mania requires at least a week of unusual or incessantly heightened, grandiose, or agitated mood, in addition to 3 or more of the following symptoms: exaggerated self-esteem, sleeplessness, pressured speech, flight of ideas, reduced ability to filter extraneous stimuli, distractibility, increased activity with increased energy, and multiple grandiose high-risk activities involving poor judgment and severe consequences, like spending sprees, sex with strangers, and so forth. There are different types of bipolar disorder. Bipolar 1 has more manic episodes with at least one depressive episode. Bipolar 2 has more depressive episodes with some episodes of hypomania. Bipolar mixed cycles between mania and depression. Bipolar 2 can be particularly difficult to diagnose, as the person is most likely to complain of depressive symptoms. Bipolar is treated with medications. Lithium is considered the gold standard, but we also use anticonvulsants as mood stabilizers. Things to remember: with lithium, monitor levels. It competes for salt receptor sites and can affect calcium, potassium, magnesium, and glucose. Carbamazepine or Tegretol. Be sure to monitor levels and watch for agranulocytosis. Divalproex, valproic acid, or Depakote. Be sure to monitor levels and their liver function. Gabapentin or Neurontin. Lamotrigine or Lamictal. Topiramate or Topamax. And oxcarbazepine or Trileptal. Some antipsychotics may be used in conjunction with the mood stabilizers and antidepressants. Ziprasidone or Geodon, Lurasidone or Latuda, and quetiapine or Seroquel are the most effective. Psychotherapy may also be useful in the mildly depressive or normal portion of the cycle. If the patient is manic, it will be very difficult to get a history from them. They're likely to have difficulty focusing and will jump from topic to topic. You may need to talk to family members to get the history in several short sessions, rather than one long session. When manic patients have a hard time holding still, they're likely to move around a lot and experience psychomotor agitation. Speech is likely to be fast and pressured. Clothing may be brightly colored and flamboyant. The patient may also remove clothing at inappropriate times and in inappropriate places and need redirecting. Mood tends to be euphoric and grandiose. Affect may be very labile, with the patient ranging from lively to tearful. Thought process and content tend to be confused with racing thoughts and flight of ideas. The patient may not be able to communicate in ways that others understand. The patient may be oriented to person and place, but usually not to time. Intellectual functioning is generally difficult to assess, as the patient has trouble concentrating and answering questions, or they claim to have abilities they don't actually have. If they're also psychotic, they may hallucinate. Judgment and insight are impaired during mania. They're impulsive and act before thinking about the action. They don't see their behavior as a problem. They can be easily angered and strike out at others. They have an inflated sense of self-concept and think they can do anything. Those with mania have a hard time fulfilling their roles. They have trouble at work or school, if they even go. They're too distracted to pay attention to their children or ADLs. They'll likely start several projects but be unable to complete them. They like to socialize but don't recognize their inappropriate behavior. Patients with mania can go days without sleep or food. They may not see the need for personal hygiene because they're too busy and have other things to do. They may not understand the risks of certain activities and can injure themselves. Once you have gathered your data, you'll formulate a nursing diagnosis. Some to consider include risk for injury, imbalanced nutrition less than body requirements, noncompliance, self-care deficit, and disturbed sleep pattern. Outcomes may include the patient will not injure self or others, the patient will establish a balance of sleep, rest, and activity, the patient will establish adequate nutrition, hydration, and elimination, the patient will engage in self-care activities, and the patient will engage in socially appropriate activities. Interventions can include providing for safety, meeting physiologic needs, providing therapeutic communication, promoting appropriate behaviors, managing medications, and providing both the patient and family with teaching. Suicide is the intentional act of killing oneself. Women are 4 times more likely to attempt suicide, but men are more likely to complete suicide. Men choose more lethal methods. They tend to shoot themselves or hang themselves, while women tend to overdose or cut. Psychiatric disorders are at an increased risk for suicide, and they include depression, bipolar, schizophrenia, substance abuse, PTSD, and borderline personality. Suicidal ideation is thinking about killing oneself. Suicidal ideation can be either active or passive. Active suicidal ideation is when the person thinks about and seeks ways to commit suicide, while passive ideation is when the person wants to die or wishes they were dead, but has no actual plan. It's a difference of, I want to go home and kill myself by overdosing on my medication, when compared to, I wish I could go to sleep and not wake up. Suicide involves some ambivalence. See box 17.2 in your book. It has myths and facts about suicide. When doing a suicide assessment, be sure to ask about personal and family history, as both increase the chance of the person attempting. The person is at greatest risk during the first 2 years after an attempt, particularly the first 3 months. There are warnings of suicidal intent, and there may be statements of intent. Direct statements such as, I'm going to kill myself. Indirect statements such as, I want to end it all, both indicate suicidal ideation. The person may engage in risky behaviors such as speeding or driving recklessly. A lethality assessment looks at the lethality of the person's plan. Check to see if the patient has a plan to kill themselves. If so, what is the plan and is it specific? Do they have the means to carry out the plan? For example, if they want to shoot themselves, do they have access to a gun? Finally, if they carry out the plan, is it likely to be lethal? Have they made any plans for death, such as giving away prized possessions or writing a suicide note? Outcomes for a suicidal patient include keeping the patient safe from harming themselves and others. We want to help them develop coping skills that don't involve self-harm. This may involve a no suicide contract, making a list of positive attributes, getting adequate sleep and nutrition, and so forth. Interventions can include an authoritative role to help keep the patient safe, providing a safe environment, which can include a contraband search, and helping the patient create a support system list so they know who they can call before they're in a crisis situation. Suicide can feel like the ultimate rejection for family and friends, that their help wasn't good enough or that the person didn't care how they would feel. Family and friends may feel guilty for not knowing the person felt suicidal and not picking up on signs that they felt that way. Family and friends will need to go through the grieving process and will have a lot of feelings about the suicide, like guilt, shame, anger, and sadness. Other family members may complete suicide, feeling that they now have permission to do so. Families can disintegrate after a suicide. As the nurse, we need to show unconditional positive regard for the person who is considering or has attempted suicide. We need to show the patient that we believe they can be helped and get better. Don't blame the patient or try to make them feel guilty. Remain non-judgmental with your tone of voice, facial expressions, and body language. Be aware that no matter what we do, some patients will still complete suicide. Make sure you have the resources available to you to help you cope with the feelings that you may experience. There are legal and ethical considerations surrounding suicide, particularly assisted suicide. Oregon was the first state to make assisted suicide legal, but know that there are safeguards to protect people. Oregon's law is called the Death with Dignity Act, and it allows a person to self-administer physician-prescribed medication with the intent to end one's life. There are 4 requirements. The person must be at least 18 years old, they must be an Oregon resident, they must be capable and able to communicate healthcare decisions, and they must be diagnosed with a terminal illness that can lead to death within 6 months. Steps to get the prescription include 2 oral requests to the doctor at least 15 days apart, a written request to the doctor with 2 witnesses, the prescribing and consulting physicians must confirm the diagnosis and prognosis, the prescribing and consulting physicians must determine if the patient is capable. If either physician feels the patient is impaired, then the patient will be referred for a psychological exam. The prescribing physician must inform the patient of feasible alternatives, and the prescribing physician must request that the patient notify their next of kin. Ethical considerations come from those who feel that people should be able to decide how to end their own life if they are terminally ill, and those who feel suicide is against humanity and religion. There are also groups who want the laws to change to allow healthcare professionals and family members to assist with suicide for the terminally ill. As a nurse, we may need to provide care to terminally or chronically ill people. It's our job to provide supportive care to our patients and their family as they work through the difficult decisions they may face surrounding end-of-life care or discontinuing life support. Depression is common among the elderly, and there's an increase when they're medically ill. The elderly have psychotic features with depression more often than younger people do, and they have an increased intolerance to the side effects of antidepressants. ECT is used more frequently with the elderly as they respond to it more quickly than they do the medications. The elderly also have an increased risk of suicide, so rapid treatment may be needed. Nurses are frequently the first healthcare providers to recognize symptoms of mood disorders. Family members may report symptoms of withdrawal from activities, trouble eating or sleeping, complaints of being tired all the time, or sadness. They may also mention periods of euphoria, excessive spending, or the person changing clothing styles to loud clothing or brightly colored. Documenting and reporting these behaviors can help the patient get treatment. This is particularly important as it's estimated that up to 40% of those with a mood disorder don't get treatment for it. Those with depression can be successfully treated in the community by a variety of providers, such as the psychiatrist, advanced practice nurse, or their PCP. Those with bipolar, however, will need to see a psychiatrist or a psychiatric advanced practice nurse for effective treatment. Mental health promotion includes education to address the stressors that contribute to depression, particularly in women. These programs work on increasing self-esteem and decreasing loneliness and hopelessness. There are also efforts to improve the treatment of depression in the primary care setting through screenings, diagnosis in the primary care setting, and using evidence-based protocols for treatment. In the adolescent population, prevention and early treatment are particularly important as suicide is a leading cause of death for this group. Screenings for the early detection of risk factors can lead to referrals and early interventions. Risk factors include family strife, parental alcoholism or mental illness, a history of fighting, and access to weapons in the home. Bullying and cyberbullying also need to be monitored by parents, family, and schools to help decrease victimization and to help prevent suicide. Nurses who work with those with depression may empathize with the patients and feel sad themselves. Be sure to monitor your own feelings and maintain a therapeutic relationship with your patients. It can be very frustrating to work with manic patients as they may engage in the same behavior repeatedly and require frequent redirection and limit setting. You may feel exhausted after working with them. Be mindful of your own attitude about suicide in order to effectively help your patients. Don't try to fix a patient's problems, but use therapeutic techniques to help them come to their own solutions. Nurses can also use the coping skills we encourage the patients to use, particularly journaling and talking about your feelings with your colleagues.